Greetings and welcome to this video on antibiotic series. In this video, we'll discuss about the first generation cephalosporin drugs, that is Cefazolin and Cephalexin. Cefazolin is widely available as IV drug and Cephalexin as the oral counterpart for Cefazolin. In this video, we'll discuss in detail about the range of organisms of coverage of Cefazolin and Cephalexin of the first generation cephalosporins, its adverse effect, the contraindications, and what it does not cover, and the must-know facts. If you're new to this channel, do like and subscribe and share it with your friends. This is Medicine Beyond Harrison's. Let's get started. So, Group 1 cephalosporins, the big picture. This is cefazolin and cephalexin drugs. These are very narrow spectrum drugs which has excellent stewardship approach, highly effective for methicillin sensitive staph aureus and streptococcus species. So it is often underused in favor of broader agents, but whatever the broader agent you go, it is always lesser than cefazolin and cephalexin for these two organisms. So even if you go for vancomycin, cefazolin is better in treating MSSA than vancomycin. The mechanism of action, it is basically a beta-lactam drug, beta-lactam antibiotic, binds to penicillin binding protein and inhibits the cell wall synthesis. Again, it's time-dependent killing. Time above the minimum inhibitory concentration is the basic method of killing. So the dosing frequency and the duration above the minimum inhibitory concentration matter more than the peak dose. So it is a bactericidal drug, which is a very important factor for killing these MSSA organisms. So penicillin allergy is not at all a contraindication for cefazolin. This is a widely misunderstood fact that when a patient is penicillin allergic and having a cellulitis probably due to MSSA or bacteremia due to MSSA, then cefazolin is not used because of penicillin allergy. In fact, most of the penicillin allergy are mislabeled. More than 90% are currently mislabeled as penicillin allergy. If you are new to this channel, we have already put a video on penicillin. In that video, we have discussed in detail about what is actual penicillin allergy and how to delabel a patient that they are penicillin allergic. So cefazolin has a unique side chain, so no cross-reactivity with other beta-lactams. Exception is cefazole, which is not commonly used nowadays, can be used in patients with Nafcillin hypersensitivity also. So cefazolin is among the safest beta-lactam in the penicillin allergy group. So drug-drug interaction, mainly it interacts with propion acid and phenytoin. Propion acid inhibits renal tubular secretion, so it increases the cefazolin half-life and can lead to toxicity. Phenytoin displacement from the albumin of cefazolin, there is increased free phenytoin levels, so always monitor closely when the patient is on phenytoin. Side effects, generally these beta-lactam drugs, all these have drug fever, drug rash and transaminitis. Hematological rarely can cause neutropenia, thrombocytopenia and autoimmune hemolytic anemia and count positivity, and neurologically can cause seizures, delirium in some cases, especially in case of renal failure. Cefazolin is a workhorse. It is the drug of choice for non-purulent cellulitis, empiric therapy, MSSA infections including bacteremia, and streptococcal infections group A, B, C, and G. Nowadays, it's even the most important prescribed drug according to the IDSA standard guidelines for free of prophylaxis of infections. So low resistance pressure, so it is an excellent stewardship choice. So remember the drug of choice for non-purulent cellulitis, MSSA infections including the bacteremia and streptococcal infections is cefazolin. Cefazolin versus Nafcillin. Cefazolin has less nephrotoxicity, less hepatotoxicity, easier dosing, Q8 hourly versus Q4 hourly for Nafcillin, better tolerability and similar and superior outcomes in bacteremia. So Nafcillin is reserved only for rare scenarios, especially severe CNS infection where cefazolin data is debated, though cefazolin is still fine. Spectrum, gram positivity, we have already discussed the MSSA organisms, Streptococcus groups A, B, C, and G, other Streptococcus also, Streptococcus pneumonia, penicillin sensitive strains, coagulation negative staph aureus, if oxacillin sensitive, and Staphylococcus saprophyticus. All these organisms cefazolin covers. In case of penicillin allergy sensitivity, the guaranteed cefazolin sensitive for all organisms, but generally reliable is for Streptococcus. So you can use it for even for penicillin, all the penicillin sensitive organisms. So when the organism is penicillin sensitive, uh, guaranteed cefazolin sensitivity is there for that organism, except for Streptococcus species. So in case of Streptococcus species, only use cefazolin if it is sensitive to penicillin. So community acquired strains of E. coli, Klebsiella, protease also it is sensitive, but it is not useful for empiric gram negative coverage. It can be used as a step down option once sensitivities are known. Cefazolin dosing is usually given Q 2 grams IVQ 8 hourly. If the standard GFR is more than 50. So indications for Q 6 hourly is morbid obesity, CNS infection, and in cases of augmented renal clearance. So indications for Q 8 hourly dosage is bacteremia and endocarditis. Cefazolin renal dosage adjustments is done. If the GFR is less than 50, 1 to 2 gram Q 12 hourly can be given, and if it's less than 30, 1 gram Q 12 hourly. If it's less than 10 ml, it is 0.5 to 1 gram once a day. And in case of intermittent hemodialysis, 2 grams post dialysis dose is usually given. In case of obesity, use the upper limit always. So it is a moderate molecular weight, that is 476 gram per mole molecule, which is hydrophilic, only given as IV route. IM is impossible. Protein bonding is almost 80% with very low volume of distribution, only 0.2 liters per kg. The extracellular fluid is very good penetration into the lungs, bones and joints, prostate, and even the bile. So CNS penetration is adequate. Previously, it was thought that there is no CNS penetration for cefazolin and usually not used for CNS infections, but now it is considered to be adequate CNS penetration, so you can use it even for CNS infection instead of Nafcillin or oxacillin or flucloxacillin. Cefazolin elimination, the renal excretion is minimally metabolized, 90% is excreted unchanged in the urine. So half-life is around 1.5 to 2 hours. Case of end-stage renal disease, it can even be in the blood for more than 40 hours. Transition to oral, this is where the importance there. Once you treat the patient with cefazolin IV, you can transition the patient to cephalexin. So oral equivalent of cefazolin is cephalexin. So in my clinical experience, we have treated a patient with infective endocarditis with multiple abscesses having MSSA organism. We have treated with cefazolin. The usual guidelines for MSSA treatment is when the blood culture comes as negative during the therapy of cefazolin, which is repeated every alternate day, or in case of resource-limited setup, every third day. Once the blood culture remains negative, from the date of first negative blood culture, you have to give the cefazolin drug for 14 days. That is what is the standard guidelines. After that, you have to continue cefazolin for 2 more weeks. So this is the guideline. So we use cephalexin for as a step down therapy for MSSA organisms and infective endocarditis, even for bacteremia. It is the oral equivalent of cefazolin. So enables early discharge and step down therapy. It has the highest oral bioavailability among beta lactams, cephalexin. Cephalexin contraindication is the same allergic reaction. Generally, beta lactam discussion applies. So if the patient is having penicillin allergy, it's not equivalent to having beta Cefalexin allergy, only the side chain matters. If you have not seen that video on penicillin, go and see that video. You will understand more about allergic reactions to penicillin and how to prevent that. So, interactions in case of iron and zinc, there can be decreased absorption. Probenecid increases the drug level, lopitolide increases the drug levels, and methotrexate increases the methotrexate levels. The side effects again diarrhea, nausea, and vomiting, dyspepsia, and again the same penicillin group of drugs or beta-lactam drugs can cause drug rash, eosinophilia, and transaminitis. Again, neutropenia, thrombocytopenia, and CNS toxicity very rarely. Spectrums almost the same as cefazolin. Gram-positive Streptococcus A, B, C, G group, MSSA, Streptococcus pneumonia if it is penicillin sensitive, and Staph saprophyticus. Gram-negative again E. coli, Klebsiella, and Proteus, but it is not the first line group of antibiotic. Only the third generation cephalosporin becomes the first line drug of choice for these organisms. It can be used as a step-down therapy. Common uses is non-purulent cellulitis and uncomplicated cystitis. You can use it. So, for streptococcal infections, penicillin-sensitive staph pneumonia, MSSA infections in case of empyema, and gram-negative UTI, if sensitive to cefazolin, you can use it as a step-down therapy. So, cephalexin dosing is 500 milligram Q6 hourly, 4 times a day dose. Can be up to 250 to 500 milligram. Cellulitis, it is 500 milligram Q6 hourly. In case of cystitis, 250 milligram Q6 hourly. Maximum dose is 1 gram for Q6 hourly. For gram-negative bacteremia, step down. So adjustment is GFR 10 to 30. If it is less than 30, go for a Q8 hourly to 12 hourly dosage. If it is less than 10, twice day dosage. So in case of upper range for obesity, can go up to 1000 milligram, that is 1 gram Q6 hourly dosage. It is also a moderately high molecular weight molecule, that is around 365 grams per mole with a bioavailability of 90%. This is the main transporter, PEP T1 transporter. It mediates the absorption of this drug into the blood. So food does not affect the absorption. The reliable absorption even in gastrointestinal disease is there because of this availability of transporter TEP-T1. The distribution, it is 5 to 15 percentage protein bound with a very good volume of distribution, high volume of distribution, good levels in lungs, skin, pleura, bone, and joints, but no CNS penetration. That is the difference between cefazolin and cephalexin. There is no CNS penetration in cephalexin. So in this case, if you suspect a CNS infection, you want a oral drug, you can go for Nafcillin or flucloxacillin or other groups of drugs which are available orally. So elimination, renal elimination is there, which is unchanged. Half-life is normal, around 1 hour. In case of end-stage renal disease, it can go up to even 16 hours, the half-life. So clinical strategy, the final important thing that you need to know, in case of non-purulent cellulitis, you can go with start with IV therapy with cefazolin. For MSSA bacteremia also, then you can transition and step down therapy to cephalexin. Once the clinical improvement is there and the patient can tolerate oral feeds, you can go in for cephalexin. So it is the powerful IV to oral stewardship pathway, and this is the major advantage of the group 1 cephalosporin drugs. The major drugs are cefazolin and cephalexin. So common clinical mistake is for MSSA organism using ceftriaxone instead of cefazolin is a big blunder. So ceftriaxone has lesser sensitivity for MSSA organisms than cefazolin. Cefazolin remains the drug of choice. Avoiding cefazolin due to penicillin allergy is again penicillin allergy is not equivalent to cefazolin allergy. Only the side chains matter. Underdosing in obesity, you have to increase the dosage into the upper level of normal limit for obese patients. Using cephalexin for severe sepsis is also big blunder. So always go for an IV therapy, then de-escalate for an oral therapy. So for stewardship perspective, benefits there are it is a narrow spectrum, low resistant inductions, and preserves broader agents like carbapenem, tryptase for later use. So ideal for skin and soft tissue infections, MSSA, and for step down therapy. So final take home message, these are champion drugs actually, still mostly used in the common clinical practice for especially for MSSA and streptococcal organisms. So it is initially I initiated a IV therapy with cefazolin, then translated into cephalexin. Cephalexin is the best oral beta-lactam step down available for this MSSA and streptococcal species. Again, penicillin allergy is not a contraindication. Dose is appropriately chosen for the site and for the patient value. These are high value antibiotics in modern medicine. So hope you learned a lot about this group 1 cephalosporin drugs. If you're new to this channel, do like and subscribe, share it with your friends. This is Medicine Beyond Harrison's. Thank you for watching.